Welcome everyone to today's webinar. I am Abby Krause with Becker's Hospital Review. We will begin today's webinar with a 30-minute discussion on how AI can help tackle key problems across the hospital and health system, with a specific focus on throughput and patient safety. At the end of the discussion, we will open up the floor for a brief audience question and answer session. We are pleased to have Scott Becker, publisher of Becker's Healthcare, here to moderate today's webinar. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Cheryl Ranking is the Chief Nursing Officer of El Camino Hospital. She is responsible for clinical care quality, workforce management, and patient experience in all areas of nursing, laboratory, pharmacy, and respiratory. As part of her 29-year journey with El Camino, she has experienced a lot of innovation and change, including the development of one of the country's first EMR systems. Kareem is Chief Strategy and Innovation Officer for Metro Health. In this role, Kareem oversees business and corporate development, provider recruiting, integration, and the planning and market research functions of the Metro Health system. Mudit Garg serves as the CEO and co-founder of Ventus, an AI-based decision management platform for hospital operations. In his role at Ventus, Mudit works with some of the top health systems across the country, including academic, community, and safety net hospitals. Now I'll quickly turn it over to our three presenters just to give us a quick background on their organizations. So Cheryl, you want to take it away?
Yes. Good morning. Here in California, it's still morning, but it may be afternoon in other places like the East Coast. So it's a pleasure to be here this morning and introduce El Camino Hospital. We're a community not-for-profit hospital. We have two campuses, one in Mountain View, California, and the other in Los Gatos, California, just 13 miles apart. We're a 433-bed across the two campuses. We do have a long history of innovation. It's right there at the beginning of our mission statement to be an innovative, publicly accountable, and locally controlled healthcare organization. We take pride in the fact that we are independent and plan to stay that way while still remaining relevant in our market here in Silicon Valley. And we are, as was referenced, a national leader in health information technology and wireless communications. So we're excited to be here today.
Cheryl, thank you. And Abby, I'll jump in now. Thank you. Kareem, and how about yourself? Tell us just a bit about yourself.
Sure. Kareem Botros, Chief Strategy Officer over at Metro Health. We are a public hospital system in Cleveland, Ohio, about $1.2 billion in revenue, maybe 30 ambulatory sites. And next month, we will have a total of 3 hospitals. We're turning on 2 new hospitals in the beginning of January. And I'm looking forward to being a part of this panel and excited for the questions.
Great, and it's amazing what you've done both at El Camino in the Silicon Valley and what you guys have done, what Cheryl's done and their team has done out there, and what you guys have done with Metro Hospital, just amazing. Mudit, a little bit about yourself and the background on Ventus too.
Yeah, thank you. Thank you. Good morning, everyone, and thank you, Scott and Becker, for hosting us, and Cheryl and Kareem for leading this roundtable. I'm Mudit Garg. I'm the CEO and one of the founders of Ventus. My background is mostly originally in machine learning and statistics, and then probably for the last 10, 12 years in process improvement in delivery systems and applying data to improve performance in delivery systems. You know, before I start and introduce what Ventus does, in many ways, the reason I got started down this path was most health system leaders I met and continue to meet, they truly aspire to deliver world-class medicine. And what that means is the best quality at sustainable margins, but also an environment that allows clinicians to do their best work. The challenge I see is that today the delivery of medicine, unfortunately, is dependent on heroic efforts needed of frontline managers and staff. Anywhere I went, the departments where there was an amazing manager who went above and beyond, who had time and effort spent on anticipating issues. Quality was good, safety was good, experience was good. But in the process, those managers, those staff were burning out, trying to just keep all of that going. And that's in the context of where in the last few years, we've really been challenged as a health system industry to be doing a lot more with a lot less, and have seen a tremendous amount of change. And that has made everyone's jobs harder, but certainly it has made it harder and harder to continue to make those heroic efforts with a growing responsibility that everyone has to undertake today. I've certainly always believed data will have a huge role to play in transforming and helping, but up till now, in many ways, data has failed to do that. Data has come in form of mostly dashboards and reports that our administrators, staff, managers have no time to look at, and it ends up adding more cognitive load, not helping. So we went on this journey of about 6-7 years ago of starting to think about how can we design something that can help bring reliability and consistency to execution and reduce the dependency on those heroic efforts and provide a better operating environment for the administrators and for the frontline staff, and most importantly for the patients. Through our journey, what we've designed is our product, which is an AI-based, almost like a virtual air traffic control in the background that's helping manage, anticipate a lot of these decisions throughout the day across the health system. This software platform helps hospitals in a variety of areas, but most commonly in throughput and flow areas like emergency departments, operating rooms, reducing inpatient length of stay, but also some of the areas you'll hear about right now from Kareem and Cheryl, two of the leaders I think who are at the forefront of applying AI to use cases of outpatient access and patient safety. And we've been fortunate to be blessed to work with folks like them and others, ranging from academics across the country to community hospitals and safety net hospitals.
Great. Let's get started. I think the thing that I find amazing about Medit's organization is the ability to take practical uses of predictive analytics. And so let's get right to this with Cheryl and Kareem. Cheryl, operational improvement and efficiency, why have they become so important in the U.S. healthcare system? Why so crucial to your organization? You know, what's driving that? And I think just to hear it in your own words.
You know, what we're finding is more and more, of course, that our customers, our patients are demanding more efficiency, and they want to interact with a healthcare organization that's frictionless, where they can really depend on efficiency and high quality. And of course, in fact, our payers are also demanding that, and our patients deserve this. Our payers deserve to have a highly efficient organization of high quality. And strategically, it's very important for our organization to stay viable in the marketplace, especially here in Silicon Valley, where it is very competitive, as in other parts of the country. And we need to be able to offer healthcare that our community members want to use. And in order to do that, it needs to be efficient and of high quality. And frankly, creating such processes is just the right thing to do for our patients.
Right. So from just both a customer experience perspective, from an economic perspective, from the competitive environment you're in, just absolutely necessary. Kareem, you're a different hospital than El Camino is in Silicon Valley. Have done a magnificent job with your hospital and now developing some micro hospitals. Why is operational improvement and efficiency so important in U.S. healthcare and in your system?
Sure, Scott. So like many health systems, we see reimbursement headwinds and really ever increasing labor costs. We're pushing and continuing to push for provider efficiency. We're looking at, reduced care variation and workflow to help, really drive some efficiencies. But we're also keenly aware of provider burnout and frankly, the diminishing returns associated with this continual push. So, our hospital is kind of unique, right? We are focusing in on operational opportunities, and it's critical. We have a payer mix that's 50% Medicaid, 25% Medicare, and to be able to continue with 8% or better EBITDA margins, we really have to keep this bend towards operational efficiency. We really can't do it without it.
Got it. And so artificial intelligence-based solutions, what I think of as predictive analytics, and how do you actually use that? Cheryl, how did your system start to turn to using AI-based solutions? how did you get to that spot?
Yeah, well, we're particularly focused on patient safety. That's where we started our journey with AI, and we were having a problem with falls. And what we noticed is that our data within our system of record, or our EHR, becomes static. It becomes stagnant over time, and that it's not continuously updating in regard to pushing out information to our clinical staff regarding changes in the patient condition so that care plans and interventions can be changed. So the data delivered through AI is because it gathers all this disparate data from our system of record, then proactive interventions can be done because messages are then sent out to our clinicians, and they're not always chasing the changes, sorting through data, but instead it's presented to them in a way that they can take action quickly. So
great. And so let me ask you a question. Like the concept was, specifically, you used it first with trying to reduce the number of falls and try and get data to do so and get, real-time messaging to people to help improve in that area. What have results been so far?
Yeah, so since the inception of the tool and using the AI machine learning tool, we have reduced our falls by 39%, which is significant.
Sure, no, that's a significant amount. Obviously, it reduces healthcare costs, makes patients happier, and it's been. I'm going to ask you some more questions on it in terms of making it operational. But I'll wait. Let me ask Kareem a couple questions first. Kareem, how did you end up turning to artificial intelligence-based solutions? And I'd also like you to comment on, for some of those areas, what were some of the limitations on not using artificial intelligence? And Cheryl, I'd love to get your feedback too after I ask Kareem. Why weren't you able to get that 39% reduction with non-AI tools, and what was the difference? But Kareem, let me turn to you first.
Sure. So it's interesting, right? So I think what drove us really towards AI really was around the frustration with static and dashboard type tools, right? So in our example, our ambulatory network supports maybe 1 million or 1.3 million visits annually, but we have a no-show rate of 19%. And when we think about what that really, sort of drives here is that overbooking our traditional model of dealing with a 19% no-show is just to overbook on average, let's say 19%, and at a certain location it might be higher or lower. And at the daily level, that may work out perfectly fine across all of the sites. But what frustrated us the most is that you could have at a specific provider level 10 patients that are guaranteed to show. They've always showed up for all of their visits. And an average no-show overbook would have an additional 2 more patients show up, which would be frustrating for everybody. At the same time, another provider might have 10 patients that never show up on their schedule, and then overbooking by 2 people, would give that provider 2 visits out of a 10 in a morning session. So really what we've looked at is trying to get to the AI approach, which is allowing us to look at patients uniquely and how they tie into the provider and not put them in static buckets. What we're looking for is really a dynamic solution.
Gotcha. And so in the static approach, didn't give you nearly the insight into are these number of patients likely to show up or not? So this has been much more helpful in planning resources and how many patients you could book and so forth?
Yeah, so if you look at like static, and we use Epic, and statically Epic may look to assign a patient a no-show rating, regardless of any changes in their lives or their history. It's once you're triggered, you're in that segment, and it makes it really difficult to pull it out. When we look at artificial intelligence or even the machine learning, we start learning who our patients are a little bit more intimately and what may be going on with outside information that's driving are they going to show up or not. And I think that really makes a big difference.
Gotcha. And Cheryl, any thoughts on why, for your efforts, the use of non-AI based solutions wasn't as helpful?
Yes, again, that reverts back to some of the same things that my colleague was saying, in that the static information doesn't doesn't allow us to change our care plan instantaneously based on the patient's current condition. So in the example of falls, our fall risk assessment is done when the patient enters the hospital. And we take traditional approaches to prevent falls. But when a patient, practically all of our patients are fall risk, honestly, because many of them are elderly, taking medications that may increase their feasibility to fall, then we actually have to have better ways to know which patient at this moment in time is at highest risk for fall so that I can intervene on that patient right now. Because of my 30 patients, 25 of them are known to be fall risk patients. So it helps filter the data.
Gotcha. And it's not just a sort of Silicon Valley executive on his cell phone. It's actually elderly, sick patients that are more likely to fall. But this gives you data on who's actually a fall risk. Yeah. Got it. And then, Mudit, some of your thoughts on this. Artificial intelligence and sort of defining it for us, because it's sort of this evolving field where the discussion of it. Now, Mudit's one of the brightest people I know, double Stanford degree, degrees in undergraduate as well. You know, the rest of us are just learning about what's artificial intelligence and what does it mean. Can you give us just a few moments back on what is artificial intelligence and how it differs from machine learning? But more so, just what is artificial intelligence and why is it so important?
Yeah, well, thank you for that glowing introduction, Scott. You're always too kind. But I think you're right. Like there is so much use of AI, machine learning, deep learning interchangeably that it's actually sometimes hard to know what's what. So let me actually just start by defining. I mean, at the most fundamental level, AI is really where intelligence can be exhibited by machines. And that intelligence can be different things, but usually it's, what we perceive to be intelligence changes over time. But at the most basic level, if there's some kind of a goal we want to achieve and we can leave a machine to achieve it, and it can maximize its own chances at success of achieving that goal, that machine is somehow artificially intelligent. It's able to figure out that this is what takes us to the best answer. Now, AI has been around for a long, long time. And what's different between AI and machine learning is if I wanted to have a machine maximize its chances of success, I could give it a set of rules. I could tell it, like, let's assume I'm buying and selling homes. I could tell it at a very basic level, hey, every time you see a home come up in this neighborhood and it's 3 bedrooms and it has these 4 factors, you buy it. That's almost always a good buy. And generally speaking, that rule would do better than a random chance of succeeding. So AI includes, what's different between AI and machine learning is AI includes rules-based systems that are expert-based systems, where an expert might sit and say, here are 4 factors you can take into account, and based on that, generally you have a high likelihood of succeeding.
Now, Mudit, let me ask you a question, because one of the things I've been most impressed with your organization is the ability to take this from sort of the theoretical to very practical application. And could you just give me a couple examples of what results you've seen so far with AI? I know Cheryl's talked a little bit about it. Kareem's talked a little bit about it. I'm going to go back to Kareem for specifics. But what are some of the results you've seen so far? And just a moment on how difficult to operationalize. And just short answers here, because I want to get back to Kareem and Cheryl on some of their specifics too.
Absolutely, yeah. Now, let me give you that, and then I'll maybe talk a little bit about the difference between machine learning, which might be pertinent as well. So you're absolutely right. The operationalization of anything to do with data isn't as easy in healthcare for a variety of reasons. Healthcare, most importantly, has data that is not machine generated. It's data that is human generated, first of all, and therefore tends to be noisy. And second of all, there's a lot of that data. So even while you can predict, for example, using machine learning, what needs to happen or what's the likelihood, some unknown variable might turn out one way. Let's say that my ED might run out of capacity. Just knowing that there's a 30% chance of this or a 40% chance of that isn't enough. In fact, it causes more cognitive burden on the frontline person to interpret that and make a decision. So what actually has been really important is to combine that with decision analysis, that is looking at the options in front of you and then translating that to, hey, based on this, based on everything I'm seeing it's cold outside, it's Monday after Thanksgiving, Dr. Smith is working, he turns over labs, our lab collection is slow. I actually specifically suggest you take that lab phlebotomist from this place and pull them into the ED for the next hour. That, making it really specific and prescribing something is very, very important in the operationalization of these machine learning models. And last step that is actually another one that is often not realized is it's also really important to do it in a way that it's really, people are persuaded to take action. So it has to be done in a way that it's frictionless, that we increase the motivation of people to act, that it's proactive, that they don't have to pull or go log in somewhere for that information. So that combination of what I often describe as not just predicting, but prescribing and persuading has been critical in operationalization of these types of models into different areas. We've seen good results across the board in those areas. We've seen EDs that have reduced length of stay by 15-20%, one ED that has saved over 1 million minutes in patient wait time. We've reduced unnecessary testing in one of the areas. Cheryl and Kareem are going to talk about some of the results. We've seen reductions in inpatient length of stay. We've seen reductions in the misestimated case durations in the operating room, which is a huge problem. Improvements in patient satisfaction by keeping patients abreast of our best guess of when the surgery is going to finish. So lots and lots of different areas of application where we've seen really phenomenal results so far.
Thank you. And let me ask Kareem, Cheryl talked a little bit about her results. Some of the results you've seen with scheduling, booking, other areas where artificial intelligence has been real helpful, and then a moment on ease or difficulty in operationalizing.
Absolutely. So we're just 1 month into our pilot, our artificial intelligence pilot, and we have focused primary care appointment scheduling, just like you were saying, Scott. And we wanted to look at the AI approach to incorporate various data. So we use not only the EMR data, but precipitation, temperature, weather points. And I think the other aspect of it is, really driving towards a fully integrated solution. So after maybe looking at 3 years of historical data and coming to the conclusion that a modeled result might drive like an 80% improvement on our, no-show or the result of our no-shows, it really gave us a lot of comfort to turn the solution on. So we turned the solution on the 8th of November. It is fully integrated with our Epic scheduling and automatically frees up slots without canceling prior patients, which is a huge accomplishment on our end because it really makes it less of a manual process. From a results perspective, our main campus has seen 82% accuracy on patients that were likely to not show for an appointment, which really, really helps us free up access points for our patients. And what's, I think, one of the nuances that we've uncovered from all this is that as we free up these slots, it takes less than 12 or certainly less than 24 hours to fill up those slots with new patients for the next day. So it really starts driving access with patients that need it most urgently, and it's been good. We have another couple months in the pilot.
So you're not in a situation where these patients that you could predict won't show up, or some percentage predict won't show up. Now you don't have to go back to them and say, you promise you'll show up, you promise you'll show up. Rather, you're just freeing up slots, recognizing and predicting that you're going to have X amount of open times. And this helps close down your open times.
That's exactly it. And rather than, so, historically we would have to cancel those patients or move them into a no-show slot, which started adding on to like averages, right? Average for this site might be 30% no-show. This puts a little bit more science behind it. And actually, from what we've seen so far, it's been pretty rewarding.
And Cheryl and Kareem, let me start with you. Difficulty in operationalizing. You hooked it into your Epic. Once it got hooked into your Epic, how long was the decision from first talking to, let's say, Ventus, who happens to be who you're working with here, to actually operationalizing this, and how easy to get on the floor and get people using this? Or do they have to use it? Does it just automatically free up slots?
Yeah, from a timing perspective, we probably talked to the Ventus team maybe 6 months prior to making a decision. We had to run an RFP process because we are a public hospital. We had to go through that, that model. But I think internally, the biggest challenges that we had really was the cultural change that was needed, because almost all of healthcare, around the media side, has the usage of AI almost in a displacement to providers, through clinical decision support. And so there was a certain amount of worry from our providers that we're bringing in artificial intelligence, and really it's the first step to removing them from the decision making around care for our patients. So we had to unwind quite a bit of that thinking. And we found that targeting this operational approach to decision making rather than going down the clinical side made a big difference for us. We spent a fair amount of time on the Epic solution and getting integrated with our IS team. And then I think maybe one of the other opportunities that we had to help it get adopted internally was that we had a team that was led by providers, even though it was purely an operational type issue. Having the providers lead it really helps clear the path in our system.
Right, and this isn't, just for my information, this isn't an effort that's going to displace jobs. This isn't really, that's not going to happen with this effort.
That's absolutely correct. And I think people get worried about these sort of things. And I think what we've done is really help try to say that what we're doing ultimately is just making it easier for our systems that are already in place to work without, it's working behind the scenes, quite frankly. I think our schedulers may not even, really appreciate how much is going on behind the scenes.
Got it. Great. Thank you. And I know I'm going to hurry up with a few more questions because we have a ton of questions from the audience as well. Cheryl, your difficulty in operationalizing and driving adoption by frontline teams. I mean, Kareem mentioned a lot of provider involvement in looking at this, the IS team, obviously, in integrating it with the Epic system. Some of your thoughts on difficulty in operationalizing and getting adoption.
Yes, so we're fortunate in that Ventus is just practically around the corner from El Camino Hospital. So when we were having problems with our falls and really not being able to make headway with the traditional approaches to preventing falls, we happened to be working with Ventus on another project, and they said, hey, we think we can help you. So we sat down in a room with clinicians who are actually doing the work every day, and we presented the problem. And then we realized that we were able to take information from our disparate systems and marry them together. So we could take our medication administration record and look at those medications that are, of course, potentially making our patients higher risk for falling, and also looking at our call light data. We use Roland, and some patients set off the bed alarm in our call light system a lot. Some patients use the call light a lot, which would signify patients who may be at a higher risk for fall. And then, of course, in our EHR, we have our fall risk assessment. So our clinicians said all those things are important. And so then what Ventus was able to do is, put the recipe in the background, taking all that data in, and then sending that warning out to our staff and saying, okay, we've filtered through all this data using our approach, and then they're able to send the message to the nurses assigned for the patient at the time and say, this is your patient who's most at risk for falling right now, based on all of this information that I'm filtering for you. Go look at this patient, intervene on this patient, and then the nurse is able to do that, and then intervene using a protocol. That might be moving the patient closer to the desk, or that might mean putting a visual monitor on the patient. So whatever the protocol may call for. And the nurses love that because immediately we began to see results. And so when the clinicians see frontline results, that helps them be more motivated to adopt.
Gotcha. Let me ask you a question, Cheryl, just a technical question. Which EMR platform are you on there?
Epic.
You're an Epic top. Okay, that's somebody had asked in the audience was curious. And ultimately, your operational journey, in looking at these things, rational amount of resources has been a reasonable thing to implement and operationalize.
Oh yes, because our systems were already in place there wasn't a lot of work for IT, some work for them to work with Ventus, but it was rational and reasonable approach.
Good. And so let me ask you a follow-up question. Kareem, I'll ask you first, and then Mudit, I'm going to want you and Cheryl to interject on this as well. Peers that are considering adopting AI solutions, Kareem, any advice, like 2-3 points of advice for peers that are looking at AI solutions, and then Cheryl and Mudit the same thing, and then I'm going to ask some of the audience questions. We've got a bunch of them.
Sure. So when we looked at it, we started with a very tangible, operationally focused project. It has to solve a specific, pain point for the organization. So something that's not too large. I think it is critical to have an integrated solution because having multiple systems or logins just doesn't work, and certainly in our environment. I mentioned the broad team. I think lastly, maybe filter the noise. It's almost like every software company in the United States seems to be pitching the idea that they have an ML or an AI platform that everything is based on. It's pretty overused. Take the time to really understand how dynamic and how much learning really is. I think in our RFP example, we probably had 12 or 13 responses. I would say 3 actually had a machine learning or an AI concept that was real. The others were really algorithm or probabilistic type models. So it takes a lot of energy to sort of filter through the noise.
Gotcha. And Cheryl, some of your thoughts and advice for peers that are considering this.
Yes, I would agree with Kareem in that it's very important to identify your problem. Exactly what problem are you trying to solve? And then I would say bring in your experts. Not only your AI experts, those with the background and the technical background, but in my case, with patient safety, our clinical experts, those out there doing the work, really understand how data can be presented to them that can really make a difference for changing the outcomes in a more positive direction for our patients. So we found that to be incredibly important to include them in the development of whatever solution we happen to be working on. And of course, an integrated solution. I'm totally in agreement. There are so many systems of record, data coming in to the clinicians that you've got to have full integration to get adoption from frontline staff.
And Mudit, your best advice for people looking at putting together or using an AI-based solution?
Yeah, I think my first advice to people is like really very, very carefully think about what decision are we trying to help make. Because I think oftentimes we get caught in like predicting something or machine learning. I think at the end of the day, what matters is what decision are we trying to make. And honestly, if that was, the clearer that is, the better are the chances of the right algorithm being used, the better are the chances of the right operationalization taking place, and there being success. So that's probably the most important piece. The second piece is, I think, realizing that still there's a very important aspect of change management that has to go along with this. So for us, we've developed a pretty robust customer success team that works with the frontline staff, with the managers, with executives to make sure that we are helping translate what they want into what ML and AI can do and how to do the change management around that. And then lastly, I'd say in picking use cases, much like Kareem was saying, there are lots. We've been watching movies for decades and decades around AI replacing people and things going off. Think carefully about what are use cases that are likely to drive value sooner without causing emotional angst. And in many ways, that is one of the reasons the operational use cases have been good ones to start with, in that A, they are achievable for machine learning because those are things that some human could do with 1 or 2 minutes of cognitive effort. Those tend to be achievable. There are standard work around activities that staff might already be doing that just needs to be done now reliably and proactively if the machine teed it up. And there is often a higher availability of data for those, and so there's a sufficient data and context that's captured in the system of record. So those would be my pieces of advice to, and those are some of the common characteristics in places that we worked that have succeeded in getting outcomes through this methodology.
Great, thank you. We've got just a ton of questions from the audience. Let me try and quickly tick through some of these to try and get the audience some feedback on what you guys are seeing and what you're doing. Kareem and Cheryl, let me start with you. how quickly did you start to see a return on the investment in this tool? I mean, how quickly did people start to, get practical results from it?
Did you want to start with me, Cheryl?
Yes, let me start with you, Cheryl.
Okay.
I'm sorry. Yes, exactly.
Okay. All right. So we measure falls essentially on a daily basis. So in the example of the falls, we were, within the first month or two, we were seeing a decrease in falls. Of course, we had that startup period of time where people were still learning how to use the tool. And so within the first quarter, first 3 months, we saw a reduction in falls.
And let me ask you, so pretty often, pretty quickly, and Kareem, I sort of heard the same thing from you, that pretty quickly this helped to automatically open up spots for you, and those spots were getting filled. So it sounds like your return on investment, doesn't exactly go into the cost-benefit analysis, but was pretty quick. Kareem, is that a fair statement?
Yeah, so our cost-benefit analysis really was based on the no-shows and then provider utilization. So if you have, in our specific example, we have 80% provider slot utilization, and we have about 200 or so primary care providers. So we have 40 FTEs worth of opportunity to improve by having this solution work. And we're still in the pilot phase, but the metric of success is pretty easy to dial in.
Gotcha. And let me ask you both a question. There's a great question asked by an audience member, and it really applies to both your uses of predictive analytics, artificial intelligence. When you get a false positive or a misread from the system, meaning a nurse is chased to help a fall patient that didn't have a fall, or in your case, Kareem, you end up with too many patients signed up for the day. How much challenge is in that, in terms of whether or not, you have to, what it does with provider trust and so forth? I mean, how much challenge do you have in provider trust to keep using the system and so forth if once in a while it doesn't hit things perfectly?
So this is Kareem. I think from a cultural perspective, we're really dialing it in pretty slowly to make sure that our providers are comfortable with the results, because taking over a provider's schedule remotely using a machine, quite frankly, to help overbook is somewhat intimidating, right? So what we've done is gone in with lots of checks and balances to really help us keep it in check. And as the system gets more and more knowledge and more comfort with the providers, we'll work our way up on it. So it's just really taking our time and gradually working through the steps.
And Cheryl, any thoughts on sort of frontline trust in the system and, how you address, all systems are, imperfect. How do you address, sort of, we're making improvements, we're getting better, but of course it's not going to be perfect.
Right, and especially in the clinical setting, you want to reduce alarm fatigue because this does send a message to the nurse. And so we want to make sure that those messages that the nurse receives are significant, something that is of importance. And in this instance, we're trusting that the system is presenting to a patient who's truly at risk for falls. We're trying to prevent the fall from ever happening. And so what we're able to do is then show the nurse on their unit every month, okay, this is your fall rate this month. And so look at how we have decreased the falls on your unit this month, and look at the solution we have used. And when they're able to see results of fall prevention, fewer falls, then again, it helps to increase adoption and that these tools truly are beneficial. And I'm getting fewer alarms than more.
Gotcha. That you're not getting overloaded with false positives, with alarms when there's not really a problem, that people are getting clearer and clearer about what really works, what doesn't work, and so forth. There's a great question here on hardware investment. For your work here, was there a hardware investment necessary? And Kareem or Cheryl, can either of you address that?
On my end, I think we had to buy a server because we were keeping some of the data in-house. But otherwise, I don't think it was a very broad hardware aspect.
Gotcha. And Cheryl, hardware on your side?
No, there was only software investment. Mm-hmm.
And Mudit, let me ask you a question, because a number of the questions go to other uses of the Predictive Analytics AI systems. Just a couple of other places, just maybe, Mudit, if you can give us 3 or 4 other areas that you're using this in, or you're seeing your clients use this in, population health, other areas in terms of healthcare, just maybe 3 or 4 other examples, because I've got a bunch of questions that sort of revolve around how else is this being used.
Absolutely. I think there's lots and lots of potential applications of using it. I'll give some examples. I think, for example, I mentioned on the inpatient length of stay, a fairly sizable problem with some of the hospitals in New York Presbyterian specifically. We're working on removing barriers to discharge and using that to reduce excess stays and reducing length of stay. We've worked with Mercy out of St. Louis and in several of their EDs, about 12 of them, in improving in reducing length of stay and reducing wait times, but also reducing unnecessary testing, and seen really good results in that environment. In the operating room at Stanford Children's and elsewhere, we've seen improvements by both helping manage the blocks and helping manage the case estimation, and then also just the day-to-day running of the OR, the turnarounds, and messaging to the patient. In each of these examples, what I'd love to kind of point out is that there are things in each of these examples that your staff are probably already doing in some ways, but it's dependent on that really good manager doing it, and it's very hard for them to do it consistently and reliably because their to-do list is very, very long. So it's actually really the common thread is taking those things that a really good manager would anticipate, would try to prevent, would try to manage and coordinate, and doing it such that even if that manager is not there, or even if there's a new manager who's there, the machine can help anticipate similarly, understand an issue is about to happen, and then tee it up for them to manage and coordinate around that, and therefore making it a lot easier for that to happen consistently and reliably. And when we can do that, we've seen really good results follow across use cases.
Great. I know you're having great results from your customer community who keeps on growing with you and trying to do more things with you. Victoria, you'll let me know in the background at what point you want us to sort of make sure we stop taking questions, because we've literally got another 50 questions or so, and I know we want to keep our audience fresh and have our audience get sick of the discussion. So, Victoria, you'll let Abby know that question.
Absolutely. Thank you.
Okay. Thank you.
We're going to get close to wrapping up, everybody. And if we do not get to address your questions during the webinar, we can definitely reach out to you offline to facilitate that discussion.
That's great. So let me use this time. Just it's a fascinating subject, and what's so helpful about this subject, and what I've learned about it the last couple of years, is exactly what Kareem and Cheryl are talking about. Is exactly real use applications that they're able to operationalize and very quickly start to have victories with, so it gains more and more adoption throughout their system. I know that Mudit and Victoria, there are a ton of questions that people brought in. I had someone say that they were so disappointed to leave the webinar because of the great conversation with Cheryl, Kareem, and Mudit. So thank you very much. Mudit and Victoria will follow up with people that have questions that weren't answered or try to. Cheryl and Kareem, just fantastic and right to the point and practical use for our attendees. So thank you very, very much. And Mudit, just amazing what the company that you and your team have developed over the last few years. Just really amazing and changing how things are handled and delivered. And Kareem, I thought your talk, and this isn't taking away jobs at all, it's just making people do their jobs better in a way we couldn't otherwise do it, just opening up revenue streams for you folks. And then Cheryl, your thoughts on just what this has done in terms of decrease in falls, just right to the point and so helpful. So with that, Victoria, thank you. Kareem, Cheryl, thank you. And Mudit, thank you as always. Just fantastic. Thank you, folks.
Thank you very much, Scott.
Thank you.
Thank you, guys.
Thanks, everybody. Have a great day.
Bye.
Bye.